So Bruce Arrell's my name. I'm the head of general practice and primary health care, and it's my pleasure to welcome Dr. Vanessa Selak, who's a public health trained physician and a senior lecturer in epidemiology and biostatistics. And she's going to walk us through the work she's done on aspirin and primary prevention, to take or not to take. This is a really big issue in primary care, and I was so excited when Vanessa said that she was doing this work, and she's had a publication in the Annals of Internal Medicine, which is a pretty good journal, very hard to get into. So Vanessa, over to you.
Thank you, Bruce. Thanks so much for the warm introduction and the invitation to speak to this group. It's really actually quite a privilege to be presenting to the Department of General Practice and Primary Care, seeing as actually this work arose out of that department, given that it was a consequence of my PhD, which I did under the supervision of Rainer Alley and Sue Wells. Now, let me see if I can move on to the next slide. Okay, well, what I'm going to cover is, as the title indicates, the focus of this work is around the use of aspirin and primary prevention. So I'm not going to cover the use of aspirin and secondary prevention. But what I want to talk about is really why I became interested in this topic, how I decided to address the problem as I saw it and what I found, and ultimately coming up with an answer about whether or not aspirin should be used in primary prevention. Just a bit of a heads up about my likely response though. It's not as simple as yes or no, as you probably might have already guessed. The other thing is that if you have questions, I'm really happy to take questions or requests for clarification as we go through the talk, and of course there will be some time for questions at the end as well. Now, the reason why I was interested in this topic was it arose out of my PhD, which, as I mentioned, was being undertaken under the supervision of Rainer Alley and Sue Wells. The focus of my PhD was the IMPACT polypill trial, and that trial was around the use of a polypill or fixed dose combination treatment for people with established indications for cardiovascular preventive medications. And at the time that this trial was being undertaken, this was in the 2000s, New Zealand guidelines were recommending aspirin as well as statin and blood pressure lowering therapy among people who not only had already had a cardiovascular event, but those who were at high risk of having their first event. Now, after a few false starts, and when the IMPACT trial eventually began in late 2009, 2010, we were hit by another inconvenience beyond the challenges to do with bioequivalence and stability that we've been dealing with the polypill. And this was the rather inconvenient finding of the antithrombotic trialist collaboration, individual participant data meta-analysis, which really questioned the role of aspirin in primary prevention. So we were really left wondering, well, should we be providing aspirin to our patients at high risk of primary prevention? Now, in order to try to work out how we were going to unpack this question, I took quite a close look at the work done by the ATT collaboration. Now, I guess the first thing I noticed was that if you're looking at the proportional effect of aspirin on cardiovascular events, that was broadly similar whether we were looking at secondary prevention or primary prevention. And I guess that's probably not surprising given that, whether or not someone has had a cardiovascular event is a question of degrees. Atherosclerosis is a chronic condition that develops over time. So it really would not be surprising to me that the effectiveness would be similar in the primary or secondary prevention populations. The other thing that really struck me when I had a look at that meta-analysis was when I looked at the risk factors for major bleeds, as well as the risk factors for cardiovascular events. And what the authors of this meta-analysis were able to do was, because they had access to individual participant data, they were able to work out the independent effect of each of the risk factors on not just the cardiovascular events, but also of the bleeding events. And what I was surprised to see was that many of the same things that increased your risk of a cardiovascular event also increased your risk of a bleed. And that really threw a bit of a spanner of the works in terms of the guidelines, because a lot of these were based on the assumption that if you increase your risk of cardiovascular disease, the effect of aspirin on major bleeds, well, the effect of aspirin on on the net benefit of aspirin was likely to increase. And that was predicated on the assumption that the risks would remain relatively static, irrespective of the risk on cardiovascular disease. So the other issue that was evident was that the 6 primary prevention trials that had been undertaken at that point were amongst very low risk populations. And this is probably not surprising, given that the people in those trials were healthcare professionals. So we're talking about the Physicians' Health Study, the Women's Health Study, and the British Doctors Trial. So these were all conducted in healthcare professionals who are unsurprisingly at low risk, as well as 3 other trials. Now, I knew that there were some trials that were underway at that point in time. This is in the late 2000s, early 2010s, but the problem was that they were still underway and their results weren't going to be available for some time. So I was really interested to see how I could use the data that we already had available to try to answer this question of whether aspirin was appropriate in primary prevention, and if it was, for whom. I really began to think about this issue in terms of individualized net benefit. And what I was struck by was that, well, actually, if we could take an individualized assessment of the benefit from aspirin and compare it with an individualized assessment of the harm of aspirin, then we may be able to actually make some headway into this problem. Now, in terms of determining the effect of aspirin, both on the cardiovascular events avoided and the major bleeds caused, this requires two equations. The first one is to work out what the cardiovascular risk is of an individual and multiply it by the proportional effect of aspirin on cardiovascular risk. Now, we have lots of cardiovascular risk equations. Thankfully, we now have a New Zealand cardiovascular risk equation, thanks to the fantastic work that's been done by the PREDICT team, led by Sue Wells and Rod Jackson, as well as all of the wonderful assistance of patients and primary care clinicians and making that data available. The other important thing to note is that what the individual participant data meta-analysis of the anti-thrombotic trialist collaboration showed was that the effect of aspirin on cardiovascular risk was consistent. The proportional effect was consistent, irrespective of a whole range of individual characteristics. So what that meant was that if we took the proportional effect from the meta-analysis and multiplied it by the cardiovascular risk, we'd be able to work out the likely benefit of aspirin in terms of cardiovascular events avoided. Now, similarly, we could calculate the same individual harm from aspirin by using the proportional effect of aspirin on major bleeds from meta-analyses. The problem, though, was that we didn't have a risk equation for major bleeding risk. And that was the thing that I sought to address with a team of co-investigators from the VIEW team. So what we did in order to develop a bleeding risk equation was that this was essentially a sister equation to the New Zealand cardiovascular risk equation. We used the PREDICT cohort. So this was people who'd had their cardiovascular risk assessment done using the PREDICT electronic decision support program. We restricted the analysis to people aged 30 to 79, and we removed people who had established cardiovascular disease at the time of their first PREDICT assessment. We ended up having a cohort size of just under 400,000, and over 1.6 million years of follow-up, there were nearly 4,500 major bleeds. Now, because we were interested in balancing the benefits and harms and trying to identify major bleeds that would be of similar severity to the cardiovascular events that were trying to be avoided with aspirin, we set the definition of a major bleed to be either an admission that where the cause of the admission was the bleed itself, or where the admission, where the bleed was a secondary diagnosis or not the major cause for the admission, where that bleed was associated with a transfusion. So even if it wasn't the main reason why the person was admitted, they ended up having to have a transfusion for it. So we felt that we'd set the bar reasonably high in terms of the severity of the bleeding event. And we looked at them as a composite, but we were able to also break that down into some of our sub-analyses, where we looked at gastrointestinal, intracerebral, and some other bleeds. Unsurprisingly, the most common bleeds were the gastrointestinal ones. There were far fewer intracerebral bleeds, although these were associated with a higher fatality rate. The other bleeds included things like bleeds into joints. Now, as with the New Zealand cardiovascular risk equation, we used a Cox proportional hazards model, and we developed two equations, one for men and one for women. Because we knew that the cardiovascular risk factors had been associated with major bleeds in the meta-analysis, we included cardiovascular risk factors as pre-specified predictors for our bleeding risk equation. In addition, we included other things that we knew were associated with bleeding risk, such as particular conditions and medications. Importantly, though, we were only able to include the risk factors that we had some way of measuring. And the way that the data sources that we had available to us were the NMDS, so national hospitalisation data. We also had national dispensing data, and we also had some access to test whether or not people had had particular laboratory tests done, and also to their results for people within the Auckland region. Now, this is one of the, we were able to develop the bleeding risk equations, and this table here provides you with the adjusted hazard ratios using those equations. And what you can see here are the independent effects of each of these risk factors on major bleeds. And as you can see, there are quite a lot of independent risk factors, and some of them were not surprising, but some of them we hadn't really been aware of. So, for instance, unsurprisingly, age is associated with an increasing risk of bleed. And whilst the hazard ratio of 1.04 may not look very impressive, what that translates to is a 4% increase in the risk of a major bleed for each increase in year of age. The other notable risk factors were ethnicity. So we saw higher rates of bleed among Māori and Pacific. We saw that a prior history of, we saw that smoking status was associated with bleeding risk. We also found that cancer was associated with bleeding risk, as well as a number of other risk factors, as you can see in the table. Now, after all of this effort doing the equation, I guess we were wondering whether the new trials, which became available towards the end of, in the end of 2018, whether they might actually mean that we didn't need to actually develop a bleeding risk equation at all. Now, as I've mentioned, these trials sought to identify people at higher cardiovascular risk than the 6 original randomized controlled trials that had been done, that had been assessed in the ATT collaboration meta-analysis. The most notable of these were Ascend, Arrive, and Aspirin. And unfortunately, these 3 trials didn't really hit the nail of the head or provide a conclusive answer to the question of the appropriateness of aspirin in primary prevention. And this is primarily because they weren't really able to recruit people with a high enough risk of cardiovascular disease. So they ended up recruiting people who had lower cardiovascular risk, so they ended up having fewer events than they had hoped to have. However, an updated meta-analysis that was published in JAMA last year, this included the 6 original RCTs plus some further ones that had been conducted between the time of that original meta-analysis and Ascend, Arrive, and Aspirin, as well as including Ascend, Arrive, and Aspirin, included all of the results together for those 13 trials, approximately 1 million patient years of follow-up. And that found that, unsurprisingly to me anyway, there was a continuing association of aspirin with a reduction in cardiovascular events and an increase in major bleeds. And we were able to use these updated proportional effects of the effect of aspirin on cardiovascular events and cardiovascular events and major bleeds in our cardiovascular risk equation, because we felt that actually the RCTs didn't answer our question. We still needed an individualized approach to work out whether or not for an individual the benefits of aspirin would be likely to outweigh the harms. So we developed the calculator, and actually when I say we, what I mean is Billy Wu developed the calculator using in Shiny apps. Billy is our data manager extraordinaire and our guru within the View team, and this calculator is freely available to anybody using that link. Now, this is one of the screens. This is an example of a calculation for one patient, and this is from the actual main publication of the risk calculator. So what you can do with the calculator is on the left-hand side, you can enter the patient details. And so this is demonstrating the result for a man who's 65 years of age, who is New Zealand European with deprivation quintile 3, who's an ex-smoker with diabetes, and for whom, and whose systolic blood pressure is 130, whose ratio of total to HDL cholesterol is 5, and who is also receiving lipid and blood pressure lowering medication. So what the calculator does is it provides the absolute risk for that individual of a major bleed and a cardiovascular event in 5 years. So as you can see on the top left, for this man, his risk of a major bleed in 5 years is 2% without aspirin, and his risk of a major cardiovascular event in 5 years is 12% without aspirin. If he were to take aspirin, our estimate is that he would be increasing his risk of a major bleed from up to 3%, and that he would be reducing his risk of a cardiovascular event down from 12 to 10%. And you're able to then work out quite simply, just by subtracting one number from the other, what the additional number of major bleeds caused would be estimated to be, and similarly the number of cardiovascular events likely to be avoided. Now, whilst that is able to support individual decision making, it is also of interest to work out what the likely effect of aspirin is at a population level. So we did look at that as well, and we found that if you make the assumption that one cardiovascular event is equivalent to one major bleed, that overall, for most people, they're likely to be basically having more major bleeds caused by aspirin than cardiovascular events avoided. So basically the net harm of aspirin is likely is that for most people they are likely to have net harm from aspirin, but there is still a relatively, a small and non-significant proportion of the population for whom the benefits of aspirin may outweigh its harm. And that does also depend on the assumptions that you make about the equivalence of these types of events. As I've said, we try to make them relatively similar in terms of severity, but some people may still feel that they would rather have a major bleed than a cardiovascular event. So if you make the assumption that one cardiovascular event is equivalent to 2 major bleeds, then of course the proportion of people with net benefit is likely to increase. So the upshot is, should aspirin be used in primary prevention? Well, there is no simple answer. I said that I wasn't going to provide you with a simple answer. The main thing is to consider the other interventions first. So firstly, behavioural modification, and then if medication is still required, to consider statins and antihypertensives in the first instance. However, if clinicians and their patients still want to consider aspirin as an additional preventive medication, the aspirin benefit harm calculator will provide clinicians with the opportunity to provide an individualised benefit risk assessment, and they can use that to have a discussion with their patient, drawing on what the priorities are of the patient and providing some numbers to help support that important discussion between the patient and the clinician. So here are some of the references to the publications that have arisen from this work if you want to look up any more details. And I would also like to acknowledge the considerable input of a huge number of people into this work. Firstly, the patients, clinicians, practices, and PHOs have contributed data to the PREDICT database, without whom this research would not have been possible, and Enigma, who've been involved in developing the PREDICT equation along with Sue Wells and Rod Jackson and the team at the university. The Health Research Council funded this work. I'd like to acknowledge Raina Ellie and Sue Wells, who were my PhD supervisors and encouraged me to continue developing this work on the aspirin benefit harm calculator essentially as my postdoc. I'd like to acknowledge the contribution of my VIEW team co-investigators and Billy for his work on data management and Shiny app development. Now that's all I was planning on saying. Does anybody have any questions or any points they'd like to make?
Well, that's wonderful, Vanessa. I think, it's so hard for us as clinicians. There's all this research out here, and you've gone and pulled it all together and presented it in a user-friendly way for clinicians. So what I'm going to suggest is that if you could just send a question, or say you want to ask a question on the chat, and I will kick it off rather than and then I'll ask you to talk. That's probably the best way to go. Otherwise, we'll have people talking over each other. Perhaps I could just kick off. I guess one of the things that I was struck by this was how small the relative benefits and harms are when you actually put them per 1,000. I guess that's one question. And two is, are you planning to look at the over 80s? Because I guess the next question is, should we stop aspirin in people over the 80, or who should we stop aspirin?
Yeah, so in terms of the magnitude of the absolute benefit and harm, yes, you're right, they are small. And that's why I guess the first response to this question is not, really whether or not you should give aspirin in primary prevention, but the other things that you should do first. So it definitely is only something you would consider as a third or fourth line option. In terms of the over 80s, the reason why the why the bleeding risk equation and the cardiovascular risk equation have only been developed in the people up to the age of 79 is because that's the population for whom we have reasonably representative data. Sorry, I can't even say that word. And that's because cardiovascular risk assessment has been recommended in those age groups. So we don't have a lot of data in the people that are over 80, and the people who have had their cardiovascular risk assessment done in those aged over 80 are probably not representative of all over 80-year-olds, because the people in whom GPs and nurses would be undertaking a cardiovascular risk assessment, the over 80s, would probably not be representative of all people in that age group. So we have to be careful about how we use the data that we do have in those over 80-year-olds, but we certainly are interested in exploring more that balance of benefits and harms in that group, because that's the group for whom as we know, these the benefits and harms do increase with age. That's where the there is a lot of uncertainty really about whether aspirin would be useful to start or to maintain.
Thank you, Vanessa. So Rod, we have a question from you. If you'd like to unmute and ask your question, and then we'll go on board.
Can you hear me?
Yep.
Yeah. Hey, thanks very much, Vanessa. That was excellent, and I'd just like to congratulate Vanessa on this really good work that she's done. Look, just two comments. The first one just about the over 80s. Vanessa explained why we haven't looked at over 80s yet, but we now have permission from ProCare to get a download of their total data, like on every patient, adult patient. So hopefully Vanessa will be able to look at the over 80s with a representative sample in future. But my main comment was just to do with how you balance a bleed against a cardiovascular event. And part of the reason why I raise it is that some of you will know Professor Sir Nicholas Wald from London, who wrote the famous polypill paper some years ago and developed a polypill that included aspirin. And he takes his polypill, and he got a bleed and was admitted to hospital, had some blood and went home. And the point was, he believes that a bleed should not be weighted anywhere near as much as a cardiovascular event. A cardiovascular event will cause damage to the heart. But in general, unless you get an intracerebral bleed, most of the bleeds are short-term, and if you transfuse people, you get better. So that's just my comment.
Thanks, Rod.
Any comment on that, Vanessa? I guess if it's cerebral bleed, that's not so good. And the odd person does die from a gastrointestinal bleed, but not many. So Rod's right there.
I guess the other point I'd make is I absolutely agree with Rod, but then I guess by the other side of it is that actually many cardiovascular events are quite treatable these days, and certainly our ability to treat cardiovascular events is much better than it used to be. Yeah.
Yeah, I guess the point is, I think you're absolutely right. They're treatable, but they do generally leave damage. And that was the point that Nick made. But I guess the main point is that I think in terms of our conclusions, and like that figure you had with 1-to-1 and 1-to-2, I do wonder whether it might be worth having, say, a 1-to-5, because people who read your paper are going to look at those figures, and so I think it's probably good to give them a range. That's one, and then it becomes an individual decision. I think a GP needs to be very involved with the patient, talking it through. Yeah.
I'm just going to draw on actually a question that Boyd has asked. Boyd, do you want to ask your question?
Unmute, Boyd.
Yeah, so I've just typed it in, but I'll ask it because I'm interested in how people understand the outputs that come from the calculator and how they interpret those numbers, because it's not a trivial exercise converting these numbers into things that people can understand. And is the calculator built for people to understand just as it is, or does it actually need to be walked through with a doctor?
Sure, no, that's a really good point, and I should have been upfront about that, Boyd. That calculator is designed for clinicians. And it's not designed for patients. And there's a big disclaimer on the calculator before you go into it that it's for clinicians. So my expectation would be that it would have to be used by a clinician in consultation with their patient, and wouldn't be a tool primarily for patients to use.
It would be very much a negotiation. Boyd, you're very quiet, and other people are saying so.
Sorry.
That's better.
Yeah.
That's better. Sorry. It is an issue about even then how do the GPs then translate that to explain it to their patients, and I mean Bruce and the other GPs around there about the ways you use to explain it. It's not a trivial thing. Anyway, fantastic work, Vanessa.
Thank you, Boyd.
But Vanessa, I like your reduce it with behavioural things, which would be exercise and lifestyle, blood pressure medications and statins. And once you've done that, there probably isn't much need for aspirin. I was very interested in one of the first slides you show that for secondary prevention for women, the pooled estimate wasn't just statistically significant. And yet we would say women who've had a heart attack or stroke go on to statins. Any comment on that?
Can I just shall I just try to get to the slide so we can look? Oh, whoops, hang on, let's see. So we can look at the same thing. Oh, this one here.
Yeah.
Let's have a look. Yeah, I mean, I guess my comment to that would be it looks like it's the confidence intervals are wide. So, yeah, I would be looking at the point estimate there. I don't think there's any evidence of differential effect between men and women. And certainly the ATT did a lot of subgroup analyses, and their conclusion was that there weren't differential effects in the proportional effect of aspirin in terms of in men compared with women. Although, of course, there are significant differences in the absolute effect, because the absolute risk of a bleed and of a cardiovascular event are greater for men than for women.
Right, so any other questions from the audience, other than I have a request that you sort this thing out about the over 80s, because some of us in the audience are heading in that direction. Well, everyone's heading in that direction, but some are closer than others. So we have a personal investment in this, Vanessa.
Fair point. Will do.
Any other questions from the audience? So it looks like we've run out of questions there, Vanessa. I think this has been a fabulous thing, and we've had a good audience today, and some very big hitters have turned up to ask questions. And thank you very much for doing this work, because it's internationally hugely important that we get our heads around this, because there are a lot of people on aspirin in primary care who I think would probably stop it if they knew how little benefit and the potential for harms they may be getting. So perhaps the last word to you, Vanessa, and then I will shut the meeting down.
Oh, look, I just wanted to thank you very much again, Bruce, for having me, and thanks everyone for joining. It's been a lot of fun to talk about this work together. Thank you.
Okay, well, I'll be putting Vanessa's talk into a YouTube, which we will send out to the whole school. We've got a few thank yous there, Vanessa, so that was absolutely terrific. And if any of you have got a topic you'd like to present for next month's research meeting, that would be great too. So thank you very much, Vanessa. That was a real star meeting.
Thanks so much, Bruce. Thanks, everybody. Take care.
Bye-bye.